Hello everybody. Today we are going to discuss about the ISCCM position statement for dengue fever. So dengue is one of the commonest cause of undifferentiated acute febrile illness in India as well as Southeast Asia. Nearly two-fifths of the world population is at risk of infection and nearly 96 million infections reported worldwide. It is the major cause of concern across the globe. It is caused by flavivirus, which is transmitted by Aedes aegypti and the albopictus mosquitoes. There are four known serotype of dengue virus, that is dengue virus type 1, type 2, type 3, and type 4. And all strains are efficient in causing critical disease due to dengue hemorrhagic fever and dengue shock syndrome. The fifth serotypes follow the synaptic cycle, unlike the other four serotype which follows the human cycle. Apart from the mosquitoes, the various may be transmitted through the blood products, needle stick injury, and mucocutaneous exposure. But the mortality rate is quite alarming in the dengue fever, that is, it is as high as 20%. Now about pathophysiology, the critical step for the virus infectivity is mediated by the major viral protein that is binding to the host cell. So the clinical manifestation of the dengue virus infection are attributed to the direct viremia and subsequent immune response. So the dengue virus infection causes illness ranging from the mild and non-specific fever to the life-threatening complications like dengue hemorrhagic fever and dengue shock syndrome. So the primary infection with one serotype generally provides lifelong immunity to the infection with same serotype. Virus protein cross reactivity to the serotypes may cause secondary immune response resulting in complications in the form of organ dysfunction during secondary infection. The cardinal feature of severe dengue infection is capillary leak syndrome, which is characteristically absent in mild disease. This pathophysiological abnormality arises due to endothelial and vascular permeability and the glycocalyx disruption due to toxic mediators. A large number of mediators have been implicated in severe dengue infection. The prominent ones are nitric oxide, interleukin 6, interferon gamma, and the free vascular endothelial growth factor. A complex interplay of various biochemical mediators and endothelium is responsible for clinical manifestation and complication in dengue. The hematological predominant abnormality included elevated levels of 1 Willebrand factor, tissue plasminogen activator, and platelet factor inhibitor. So the dengue is mainly hepatotrophic virus, and the some amount of liver function is evident in all patients. So in the absence of severe abnormalities in the hepatic synthetic function, frank coagulopathy is rarely seen, except in patients with shock and multi-organ dysfunction. So the combination of vasculopathy, endothelial dysfunction, and thrombocytopenia predisposes to the bleeding manifestation. Now about clinical presentation. The clinical presentation of dengue virus infection has been described systematically by WHO and expert group, which did not feel, and it is as follow. So basically, the clinical presentation is divided into the three phases, like febrile phase, which lasted for the day 2 to day 7. Critical phase lasted for the 4 to 5 days, and the recovery phase, which is beyond day 6. So the febrile phase is characterized by the acute onset fever with headache, body ache, retroorbital pain, and the upper respiratory infection like symptom and occasionally GI. There will be the flushing of skin and rash that may appear on day 4 and 5. It starts from the neck and face and progress to the periphery, and it may disappear when fever disappears. In some patients, itching and rash may persist even after fever disappears. Now about critical phase, it is mainly characterized by capillary leak. This results in the fluid accumulation in the pleura peritoneum, and it is confirmed by the hemoconcentration. So the fluid leak results in the shock and the decreased organ perfusion. Abnormal homeostasis may result into the clinically overt bleeding or falling HCT with clinical deterioration. So the organ dysfunction may manifest. This period normally lasts for 36 to 48 hours. Now about recovery phase. Recovery phase is characterized by the return of extravascular fluid to the vascular compartment with improving organ function. There is clinical improvement in the symptom. It starts after day 7 and lasts for 2 to 3 days. In some patients, the longer convalescence may be expected. Some patients may pass on to the expanded dengue phase with persisting organ dysfunction. Now, the clinical features of the dengue fever and severity. So, dengue fever is characterized by the acute febrile illness of 2 to 7 day duration with 2 or more of the following manifestations like headache, retroorbital pain, myalgia, arthralgia, rash, and the hemorrhagic manifestation. So, the dengue hemorrhagic fever is characterized by uh, clinical criteria of dengue fever plus hemorrhagic tendencies, which is characterized by positive tourniquet test, Patechi's ecchymotic purpura, and any kind of bleeding from mucosa, GI tract, and injection site, and the any other site. Or plus there should be thrombocytopenia, that is platelet count should be less than 1 lakh, plus there is evidence of plasma leakage due to increased vascular permeability, which may be manifested by one or more of the following, like rise in average hematocrit, more than 20% drop in hematocrit following volume replacement treatment compared to baseline, a sign of plasma leakage, that is pleural effusion, ascites, and hypoproteinemia. Then dengue shock syndrome. It is characterized by the all above criteria for dengue hemorrhagic fever, with evidence of circulatory failure manifested by rapid and the weak pulse and narrow pulse pressure or hypotension for age, cold clammy skin, and the restlessness. So now we'll see what is expanded dengue syndrome. So the expanded dengue syndrome basically involves the organ failure. It may be CNS. So if it is involving CNS, it is characterized by encephalopathy, encephalitis, seizure, or ICP. If organ involvement targets the GI system, then it is manifested as hepatitis, fulminant hepatic failure, acute pancreatitis, and acute cholecystitis. If it is renal, then it can manifested as acute kidney injury, ATN, HUS, and TTP. Then, if it is CVS, then it is characterized by myocarditis and pericardial effusion. In case of respiratory system, it is characterized by the pleural effusion, pulmonary edema, ARDS, and the pulmonary hemorrhage. In case of eyes, it is characterized by the visual loss and conjunctival hemorrhage. Now let's see the definition. So the definition of the dengue fever is febrile illness of 2 to 7 day duration with mild to moderate grade fever with myalgia, arthralgia, headache, retroorbital pain, rash, and the cutaneous bleeding. There may be appearance of rash and defervescence. Severe dengue is defined as dengue fever with capillary leak, bleeding, shock, or organ dysfunction. Now about dengue fever with warning symptom. So it is characterized by persistent vomiting, abdominal pain, discomfort, mild bleeding, evidence of pleural effusion, ascites, cold and clammy extremity, decreased urine output, tachycardia, hypotension, rapid fall in platelet count or hematocrit of more than 45%. All this is classified as dengue with warning sign. Now about dengue hemorrhagic fever, it is characterized by the hemorrhagic manifestation with evidence of capillary leak and thrombocytopenia. Dengue shock syndrome is characterized by fever with tachycardia, low pulse pressure, cold clammy extremity, and restlessness. In expanded dengue fever, as I mentioned before, it will manifest as the organ dysfunction. It may involve central nervous system, heart, a GI system, liver, renal, respiratory system, or eye. Now about triaging of the patient. So if the patient is manifested with the milder illness, then we can manage this patient on home basis just by giving the oral fluid supplement, antipyretic, and other supportive therapy. Now, now the patient who manifested with the presented with the warning symptoms, they require close observation. Like, and because anytime they can manifest as the dengue shock syndrome or dengue hemorrhagic fever. So who are these patients who requires close monitoring? So those patients who presented with the persistent vomiting, inability to retain food liquids or inability to drink liquid, so those who have severe abdominal pain, lethargy, restlessness, sudden behavioral changes, then bleeding manifestation in the form of epistaxis, black stool, hematemesis, excessive menstrual bleeding, dark color urine, and hematuria. Then giddiness, pale, cold, clammy hands and feet, less or no urine output for 4 to 6 hours. Then, if some patient presents with the organ failure of more than more than two organ system, and if some patient, if patient manifests as dengue shock syndrome or hemorrhagic syndrome, they requires ICU admission. Now about diagnosis. So lab diagnosis of dengue is made by detection of virus and its component like PCR and antigen test, and by the detection of serological response after infection like IgM and IgG. So during febrile illness, like day 1 to day 5 of fever onset, so PCR is useful within 48 hours, and after that NS1 can be used. For all practical purposes, NS1 antigen test is preferred. So both ELISA and the rapid commercial test are available for NS1 antigen detection. The sensitivity and specificity of NS1 antigen capture is about 80% to 100%. A single serum sample collected after day 5 of fever onset is useful for IgM detection. Commercial anti-dengue IgM kit have reported sensitivities of 21 to 99% and specificities of 77 to 98%. Serological cross-reactivity may be responsible for false positive result due to other flavivirus infection like Japanese encephalitis virus and West Nile virus. So false positive result may also be observed in patients with malaria, scrub typhus, and the past flavivirus infection. Now, about diagnosis of dengue fever can be confirmed in ER or ER and ED. So they about according to recommendation, performing NS1 antigen in first 5 days, presenting with clinical feature consistent with the dengue. So dengue IgG in patient presenting with the clinical feature consistent with the dengue by organ dysfunction within first 7 days or earlier of illness. But the expert group recommended performing dengue IgM level for establishing diagnosis after 7 days of onset of clinical symptom, which is consistent with the dengue fever. But expert group recommended that PCR for virus detection should be performed only for surveillance and research purpose. Now about diagnosis of severe dengue in ICU. Most of the patient develop severe dengue and complication in dengue fever after day 7 of illness. If patient with the confirmed dengue fever gets admitted and shifted to ICU with complication, there is no need to repeat or reconfirm the diagnosis. In case the patient has been admitted to ICU with complication without diagnosis of dengue being established, the following should be done. For patient admitted within 5 days of fever onset with organ system dysfunction, shock, dengue NS1, and IgG antibody test should be performed or ordered. If patient gets admitted between day 5 and day 7 of onset of fever with complication, then we need to perform IgG antibody test as NS1 antigen is likely to disappear and IgM antibody may not have yet appeared. So there is no recommendation to perform NS1 antigen after day 5 of onset of fever. Since NS1 antigen test is earliest to appear and IgM appears only after 7 to 10 days, a single positive value of NS1 antigen detected and IgM seroconversion should be taken as a marker of acute dengue virus infection. In patient with secondary is better indicator than single IgG value for secondary dengue infection. Now about admission in ICU. The expert group suggests that a high-risk patient with dengue fever and warning symptoms should be admitted to the ICU. Patient diagnosed with the dengue fever having two or more abnormal vital signs with warning symptom to the ICU. Severe dengue patient, a severe dengue patient should be in ICU, and patient with the dengue shock syndrome and dengue hemorrhagic fever. So it is admitting patient with thrombocytopenia. If the patient only has thrombocytopenia with no warning sign and no hemorrhagic sign, then there is no need of ICU admission. About clinical and lab parameters. Now, what clinical and lab parameters should be monitored if the patient is admitted in ICU with severe dengue fever? So, general condition, appetite, vomiting, mucosal bleeding, and mentation should be monitored every 6 to 8 hours. Peripheral perfusion like pulse rate, blood pressure, CRT, urine output should be monitored every 2 to 4 hours. Vital signs such as temperature, pulse rate, respiratory rate, blood pressure should be monitored at least for every 4 to 6 hours in non-shock patient. Now, patient admitted to the ICU with severe dengue have existing two or more organ failure, which could be clinical or abnormal lab test. So, two very important markers to evaluate reduced peripheral perfusion and reduced organ perfusion are capillary refill time and serum lactate. So this can guide fluid management in severe dengue patient as in severe sepsis. Since there is potential chance of developing new organ dysfunction and worsening existing dysfunction, it is relevant to frequently monitor different lab parameters. Since most of the parameter will not change in 10 to 12 hours, a single value every day is likely to be sufficient and should be reordered. Now, if the patient is in shock, then this patient should be on continuous vital monitoring in ICU. If this is not possible, then vital should be recorded as frequently as possible and preferably every 30 minutes. Since most of the cases can be monitored using non-invasive measures such as non-invasive blood pressure, pulse oximetry, and POCUS. Due to inherent risk of bleeding with established invasive line in patient with thrombocytopenia, this should be avoided. However, if clinically indicated, all precautions should be taken while establishing arterial and central venous access. Serial hematocrit should be performed at least every 6 to 8 hours in stable case and should be more frequent in unstable patient or those with suspected bleeding. It should be noted that hematocrit should be done before fluid resuscitation. If this is not possible, then should be done after fluid bolus, but not during infusion of the bolus. Urine output should be monitored at least every 6 to 8 hours in uncomplicated cases or hourly basis in patients with profound prolonged shock and those with the fluid overload. To maintain urine output, so the target of the urine output is around 0.5 ml per kg per hour. Now about biochemical parameters that should be monitored in ICU. So it is recommended to perform baseline hemogram and routine biochemistry at admission in all suspected and confirmed patients. So it is recommended that dengue with the warning sign, then we should do the all routine tests like CBC and hematocrit daily. More frequent monitoring is needed if patient is clinically sick. It is recommended to perform baseline USG for evidence of capillary leak in patient with dengue fever with warning signs, severe dengue and dengue shock syndrome. It is also recommended to perform radiological imaging at baseline patient with severe dengue. It is also recommended to perform advanced radiological imaging in selected cases as and when indicated. So it is recommended to evaluate for secondary HLH in diagnosed dengue patient with persistent fever and recurrence of fever beyond day 7 with new onset organ failure. So the recommended investigation include CBC, serum ferritin, serum LDH, CRP, serum triglyceride, and bone marrow examination. Now, the recommended blood investigation is CBC, blood glucose, serum electrolyte, blood gas analysis, blood urea and creatinine, liver function test, coagulation profile, chest radiograph, group and match for fresh whole blood, fresh packed red cell, cardiac enzyme or ECG, serum amylase, ultrasound if abdominal pain does not resolve, and any other test if clinically indicated. So, what are the treatment priorities? It is strongly recommended that fluid supplementation and management should be the first and the most important priority in severe dengue patients. Majority of the complications associated with dengue fever starts with patient transiting into critical phase instead of the mild symptom following by recovery. So the major culprit is capillary leak and the third space fluid loss. So hemoconcentration combined with platelet function abnormalities resulting in platelet toxicity, resulting in the rheological changes in the blood flow, causing organ system dysfunction, which is secondary to the compromised perfusion. Therefore, restoring perfusion by supplementing fluid is first priority. Now about preferred fluid. It is recommended that crystallite should be preferred agent for replacement and resuscitation. Isotope solutions such as 0.9% saline and ringer lactate should be preferred. Balanced fluid have an advantage and can reverse metabolic acidosis effectively, but they are expensive. In selected patients requiring high qualities of crystalloid, albumin can be tried to prevent excessive fluid accumulation and to prevent third space. Now, how to fluid resuscitation strategy? So it is recommended that we should start with 5 to 7 ml per kg if our patient is presenting with warning sign, but if the patient is not in the shock, then it is recommended to start fluid at of 5 to 7 per kg per hour for 1 to 2 hours, then reduce to 3 to 5 ml per kg per hour for 2 to 4 hours, and then we need to further reduce to 2 to 3 ml per kg per hour or less. It is also recommended to assess clinical status by repeating HCT at frequent intervals. If HCT remains same or rises by minimum, then continue with the 2 to 3 ml per kg per hour for another 2 to 4 hours. If worsening vital sign and rapidly increase HCT, then we need to increase the rate to 5 to 10 ml per kg per hour for 1 to 2 hours. It is also recommended when reviewing fluid infusion according to clinical status, POCUS, and HCT. Then reduce intravenous fluid gradually when the rate of plasma leakage decreases towards the end of critical phase, which is indicated by adequate urine output, fluid intake, and HCT decreases below baseline value in stable. Now about monitoring of the patient, vital sign and the peripheral perfusion 1 to 4 hourly until the patient is out of critical phase. Urine output 4 to 6 hourly. HCT before and after fluid replacement, then 6 to 12 hourly. Blood glucose and other organ function. Now about this chart is all about giving the fluid administration. So if the patient's weight is less than 10 kg, then we need to give the fluid at the rate of 100 ml per kg. If the patient's weight is between 10 to 20 kg, then 1000 ml plus 50 ml per kg. If the patient's weight is more than 20 kg, then 1500 ml plus 20 ml per kg. Now, fluid application strategy, dengue fever with warning sign and comprehensive shock. It is recommended to start IV fluid resuscitation with isotonic crystalloid solution at 5 to 10 ml per kg per hour over 1 hour. So it is also recommended assessing clinical status and the resuscitation of the patient clinically, like pulse, blood pressure, CRT, urine output, lab parameter, and by using POCUS. If we need to reduce the fluid gradually to 5 to 7 ml per kg per hour for 1 to 2 hours, then to 3 to 5 ml per kg per hour for 2 to 4 hours, and then to 2 to 3 ml per kg per hour for 2 to 4 hours, and then reduce further depending on hemodynamic status. Then we have to maintain the IV fluid administration for 24 to 40 days. If the patient is still unstable, then it is recommended to check HCT after first bolus. If HCT increases, then the repeat second bolus of crystalloid solution at 10 to 20 ml per kg per hour for 1 hour. If there is improvement after second bolus, then reduce the rate to 7 to 10 ml per kg per hour for 1 to 2 hours and continue to reduce as above. If HCT decrease, then this indicates bleeding and need to cross match and transfuse the blood as soon as possible. Now about severe dengue with shock. It is recommended initiating IV fluid resuscitation with crystalloid or colloid solution at 20 ml per kg as bolus for 15 minutes. If patient improves, then the give crystalloid or colloid at 10 ml per kg for 1 hour and then reduce gradually as above. If the patient is still unstable, then review HCT before first bolus. If HCT is low, then the continue colloid infusion at 10 to 10 ml per kg as third bolus over 1 hour and then reduce to 7 to 10 ml per kg per hour over 1 to 2 hours. Then change back to crystalloid solution and reduce the rate. So, norepinephrine is the preferred inodrop if the patient is non-responsive to the fluid therapy. So what are the transfusion triggers? If overt bleeding is absent, then falling hematocrit in unstable patient may be the indicator of occult bleeding. So it is strongly recommended against transfusion of fresh blood and the PCV in patient with mucosal and skin bleeding with hemoglobin of more than 8. So it is also recommended infusing 5 to 10 ml per kg of fresh pack red cell and 10 to 20 ml per kg of fresh whole blood in presence of fresh bleeding with hemoglobin of less than 8 gram per day. Now about role of steroid. So there is no role of steroid in patient with severe dengue and dengue with warning sign. Also there is no role of steroid in improving platelet count. Now about indication of platelet and FFP. So there is no role of prophylactic transfusion of the platelet. So it is recommended against transfusing blood in dengue fever in the absence of bleeding. It is also if one's hemoglobin is more than 8 and if there is the absence of the bleeding, then also there is no recommendation to transfuse the blood. If platelet counts are before 1,000 and if there is the absence and there is no overt bleeding, there is no role for transfusing platelet. So the expert suggests that clinician should use his judgment for transfusing platelet when the count is less than 10,000. And it is also there is no role of being precipitate in severe dengue with coagulation. So it is recommended that clinician should use his or her clinical judgment for transfusing blood product, FFP and cryoprecipitate in patient with coagulation abnormality and overt bleeding. So the administration of platelet and the fresh frozen plasma is the topic of controversy. There is ample evidence available against the use of prophylactic transfusion in patients with severe dengue with thrombocytopenia. Now, the way recommended consider prophylactic transfusion below 10% of total blood volume is lost, and if there is falling HCT in the absence of clinical deterioration in spite of adequate fluid resuscitation. Overt or occult bleeding in severe dengue and dengue hemorrhagic patient having cardiac compromise, transfusion should be done to keep hemoglobin as close to that. Now about complementary and alternative therapy. So there is no role of papaya leaf extract for improving platelet count. Also, there is no role of anti-immunoglobulin, romiplastin, and the eltropopac for patient with dengue having thrombocytopenia. So, understanding of the pathophysiology of severe dengue has also changed over time. It is now well understood that correction of organ system dysfunction is far more important than the correction of thrombocytopenia. So, by giving prophylactic platelet transfusion, there are increased risk of complication like fluid overload and drug. So, prophylactic platelet transfusion should be avoided. Establishment of therapy for cytokine reversal and plasmapheresis. So, cytokine storm is the root cause of multiple organ dysfunction in severe dengue, and it is logical to think that cytokine removal to control the damage. But there is no trial demonstrated significant benefit of this therapy in patient with sepsis, and therefore it's not included in the surviving sepsis guide. So it is also there is also recommended that these therapies are also not indicated in severe dengue fever. But plasma exchange is the bridge for the liver transplant. So if there is a dengue patient with liver involvement, then 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 we can explore the option of this plasma exchange. Thank you, guys.